My presentation is about stratified medicine, and stratified medicine is basically developing methodologies whereby we can use diagnostics, for example, to be able to stratify treatments so the patients respond first time to the best drug for them. At the moment, what we do is treat patients on the basis of one dose fits all, that everybody gets the same type of drug when they have the same disease, and that doesn't work because some patients don't respond, some patients develop side effects. Our work has been trying to develop ways of being able to improve that by identifying patients who are going to respond to the drug the first time. We tend to use all sorts of tools to identify how to stratify diseases and to stratify patient groups so they can receive the drug the first time. That starts from the patient themselves, where we need to be able to do deep phenotyping. So that's clinical phenotyping, and that clearly requires the use of either sort of databases from which may be national, which may be local, or actually going to see the patients and undertaking some detailed phenotyping on them. And then we get samples from patients, which may be DNA samples, which may be plasma samples, serum samples, and we undertake various types of omics technologies to be able to relate various predictors within those samples to their phenotype. And that provides you with the genotype and phenotype, which then allows you to be able to then take it to the next stage, which is to identify diagnostic tests which allow you to be able to predict whether a patient may respond to a particular drug or not. I think the sort of biggest advances will be better use of the health informatics databases that we have. I think they are fine at the moment, but they need to be better. We need deep phenotyping within those databases and have enough power within them to be able to identify the rare events as well as the common events. I think that's got to be an important advance. On top of that, on the technology side, we also need advances in the way we utilize these kind of new technologies so that we can integrate them in a systems fashion to be able to identify multiple biomarkers which allow us to be able to predict how somebody's going to respond. I think different people have different definitions of open innovation, and I guess the best open innovation is where it's completely open and there are good partnerships between one partner, another partner, plus several partners working together to achieve a particular goal. So the program is very interesting, very diverse, very sort of in a good group of people, and it will be interesting to spend some time here to be able to see what other people are doing from within the UK as well as internationally, and how we can interact with companies. I think it's very important. In this space, we need to be able to interact with companies who are working in digital health, really to make strides forward. Interoperability of different systems is a hugely important issue. If the different systems can't talk to each other, then we will be left with the isolated systems which don't really have the power to be able to answer the questions we want to answer. So interoperability is one of the major barriers to actually progressing in my area of stratified medicines. And as you, in my talk, I'll mention the interoperability being a hugely important aspect. I think we have a long way to go to overcome the interoperability issues. I know that some of the work that we've been doing within local NHS trusts shows that they have so many different systems, even within each individual trust, which don't talk to each other. And then when we get to the totality of what happens within the healthcare system in the UK, and getting all the systems to be able to talk to each other is going to be a major task, a major challenge, but it should also be seen as an opportunity.
Great.